All right, so good day, everyone. This is Victor from Vic-Nclex Prep Consult. All right, so let's walk with me through this NGN question. All right, so we have a 740, a 31-year-old client brought to the ED by the roommate, right? Client has a 6 years history of bipolar 1 disorder, maintained on a lithium and a quetiapine. Roommates report the client was started on a new medication by an outpatient psychiatrist sometimes last week for depressive symptoms and also began taking an over-the-counter cough preparation 2 days ago for cold. Roommate states the client seemed jittery and off yesterday evening and was found this morning shaking, swearing through the bedsheet and then speaking in fragments. Then 7:55, client is agitated, oriented to person only, intermittently following commands. Temperature is 39.6 degrees Celsius. That will be 103.3 degree Fahrenheit. Then orally, that was an oral temperature. Then the heart rate is 138 beat per minute, and then the BP is 168 over 96 millimeter mercury. Repeated 5 minutes later, the BP was 122 over 64. Respiratory rate is 30. XPO2 is 96 on room air. Skin is flushed and profusely diffused. Skin is flushed and profusely diaphoretic. Pupils is 6 millimeter bilaterally, sluggishly, lower extremities, sustained ankle clonius elicited bilaterally, plus 4 patellar reflexes. Upper extremity tone noted to be mildly increased, but movable through fully ranged. All right. Then I have bowel sound hyperactive in all 4 quadrants. Client had 1 episode of loose stool. No recent psychotic dose change reported. Roommate confirms client has continued quetiapine at the same time. Right. Okay. Now let's look at the question. So the question says, pardon me, let me move this away. So the question says, for each finding, click to specify whether the finding is more consistent with serotonin syndrome, more consistent with neuromalignant syndrome, or is non-specific. That simply means does not differentiate between the two, right? Now when we look at this, let's look at the lab value. Let's see whether I have any lab value here. Yeah, we have lab by 810, right? So we have the creatinine kinase is if you look at it, is a little bit elevated. If you look at our white blood cell count, is a little bit also elevated. Then we have our sodium. Sodium is a little bit low. And then we have the bicarbonate. Bicarbonate is also low. And our creatinine is high. And then we have the lithium, the serum lithium level. Serum lithium level is slightly normal, right? It's normal. Right. So this is the lab result, right? So let's go back. Now, when we look at this, let's go through the case again. So we have a 31-year-old client that is brought to the ED by the roommate, right? Now, the client has a history of bipolar type 1, right? That was maintained on lithium and then quetiapine, right? So the roommate reports the client was started on a new medication by the psychiatrist sometimes last week for depressive symptoms, right? So we are looking at antidepressant here, right? So the patient was on antidepressant last week, right? The psychiatrist placed him on antidepressant, right? And also began taking an over-the-counter medication like to suppress the cough, right? 2 days ago for cold, which he had. Roommate said the client seems jittery and off yesterday evening and was then found this morning shaking, swearing through the bedsheet and then speaking in fragments. So now that's around 7:55. Client is agitated, oriented to person only, intermittently following commands. look at the temperature. Temperature is slightly high. My heart rate is also high. My BP of 168/96 is also high. Then we repeated this temperature after 5 minutes. It came low, though we have 122/64. Our respiration is too high, but XPO2 is normal on room air, right? Now, this client's skin is flush and profusely diaphoretic. That means he's sweating. His pupil reaction is 6 bilateral. So on the left eye, on the right eye, pupil reaction is 6 bilateral, but it's sluggish. How we elicit a pupil reaction is you flash a pen light in the client eye, and then normally the pupil will start constricting because we want to reduce the amount of light entering the eye, because the light can damage the runs and the cones of the retina, right? So in doing this, it's meant to be so quick, but it is sluggishly. So let's continue. Lower extremities, sustained ankle clonus. I'll take note of that word. Lower extremities, we are seeing clonus. Clonus has to be like a kind of excitability in the central nervous system. Like when you see somebody is having clonus, you're looking at excitability in the central nervous system. Like the client is agitated, like increase in hyperreflex, like the client is tilting towards seizure. Are you following? So when you hear of clonus, you're looking at excitability in the central nervous system. All right. So clonus elicited bilaterally. Then can you see +4 patellar reflexes? Have you seen it? So there's increase in the central nervous system excitability, right? Now upper, because our normal reflex we want it to be +2. Anything above +2 is hyper. Anything below +2 is hypo, right? So we're having hyper reflexia, like increase in the central nervous system excitability. So we have upper extremity tone noted to be mildly increased, but movable through full range. That means we can move the upper extremities. Bowel sound hyperactive in all 4 quadrants. Client had 1 episode of loose stool, diarrhea. That means there's increase in what? In hyper motility of the stomach, right? No recent antipsychotic dose change reported. Roommate confirms client has continued his quetiapine at the same time. Quetiapine is an antipsychotic medication. This particular case study is very, very tricky. It's a difficulty level case study. Are you following? It's a difficulty level NGN kind of case study, right? If you sit on the Nclex, you don't need to rush. You need to take your time to understand what is going on here. Now, if you go back to this case study, do you see that this client has bipolar, right? He has a history of bipolar for 6 years, and then he's been managed on because we want to really understand what is happening for us to be able to answer this question. Now, if you look at this, the client is on lithium and then is on quetiapine, right? Now, later on, they said the psychiatrist prescribed antidepressant for this client because the client reported of depressive symptoms. So you know your antidepressant, right? We have the monoamine oxidase inhibitor. I kind of use SPIT to remember those classes of drug. They have the selegiline, phenelzine, isosocarbonyl, and then trinyl-cyclopramide. Even rasagiline is also one of these monoamine oxidase inhibitor. Then we have the SSRI, right? That is a selective serotonin reuptake inhibitor. This is where we have the citalopram, escitalopram, fluvoxantine, and sertraline. They are all SSRI. Then we have the TCAs, tricyclic antidepressant. These are the ones that end in pramine and tryptylene. You have the nortriptyline and imipramine and the rest of them, right? Then we also have the non-epinephrine serotonin reuptake inhibitor. An example of here, I think, is the venlafaxine, something like that. So take note of that. Now, this antidepressant, client is on it, and then we are seeing these symptoms. Now, it's not testing us on to know those symptoms that are peculiar to serotonin syndrome and that is peculiar to neuromalignant syndrome. Are you following? And also let us know if it's non-specific. So we are looking for the symptoms that will help us to tell us that this client is actually having serotonin syndrome. This case study here presented tells us that the client is having serotonin syndrome. How? This client was started on antidepressant and this client is on lithium. when you're on lithium and then you are on antidepressant, it kind of increases the serotonergic receptors in your body. So we are going to have what we call a serotonin kind of a syndrome. When you look at the signs and symptoms this client present here, it is typical to serotonin syndrome. How do you differentiate serotonin syndrome from neuromalignant syndrome on the Nclex? Because this is a huge, high yield tested area on the Nclex, right? Now, in serotonin syndrome, client is going to be on antidepressant. Are you following? Antidepressant, any of these antidepressants we have mentioned, monoaminosidase, your SSRI, your SNRI, that is serotonin non-epinephrine reuptake inhibitor, and then, or your TCA, any of them. Then if it is neuromalignant syndrome, this client must be on antipsychotic medication. In as much as possible, the client is on quetiapine. But what this client is presented here with, it is what? Neuromalignant, it is what? Serotonin syndrome. Sorry, not neuromalignant syndrome, serotonin syndrome. In serotonin syndrome, your signs and symptoms with someone, we are going to have increased excitability of the central nervous system. Excitability of the what? Of the central nervous system. That is what we are going to be having in serotonin syndrome. So you're going to have what? You're going to see hyperreflexia. Their tendon reflex will be so high, they're easily irritable. Are you following? Their hypermotive active, their ball sound is going to be so high. That's why I see this client is having diarrhea. So you think of serotonin syndrome high because serotonin, when you look at serotonin is a excitatory neurotransmitter. But in neuromalignant syndrome, we are not going to be seeing excitation here. Rather, everything is going to be low. Are you following? Although blood pressure can fluctuate in both of them. Are you following? But the tendon reflex is going to be low because in neuromalignant syndrome, we are going to see what we call a lead pipe kind of rigidity. A lead pipe kind of what? Rigidity. Client is going to be stiff. You can't be able to move the joint and the rest of them. Although temperature does not really distinguish both of them, because we're going to see temperature in rise in neuromalignant syndrome, and then we're going to see temperature rise in serotonin syndrome. But what in neuromalignant syndrome is that I want you to take note that it is slow in onset. It can take up to 4 to 1 week before it builds up. It's usually a side effect of antipsychotic medication. But in serotonin syndrome, it occurs within minutes, within hours. So it is more of acute. And is a side effect when somebody is on what? Any of those serotonergic medications, such as your antidepressant. So you being on antidepressant and being on lithium is going to make this client to go into what? Not only on that, look at it. Also, the client is taking a cough suppressant. And we know this cough suppressant, they are all stimulants. Right? They are stimulants, so they are going to worsen it and make the client to go into what we call serotonin syndrome. So with this now, we have been able to establish that what we are seeing here is serotonin syndrome. You see how the case study came, tried to twist it, and then mention quetiapine, and then just tell that the client was prescribed, was treated for for depression. Are you following? So you need to pay attention. This is a high-level Nclex question, and this is what Nclex wants to use to test you. Those difficulty level questions that you need to answer correctly, that is meant to make you to be above the passing line. So take note, serotonin syndrome is faster, it's acute. Unlike in NMS, it is chronic. It takes time. It takes approximately 3 to a week before it builds. When somebody is on an antipsychotic medication and then want to start manifesting with NMS, you will not see it on the first day he starts. You will not see it on the second day. It will be around the third day, the fourth day before it starts manifesting. But serotonin, immediately you start seeing it. All right, let's go. So we are looking for those signs and symptoms that is more specific to serotonin syndrome, right? Based on what we have here, right? Now, sustained ankylosing with +4 reflexes. Remember I told you, serotonin syndrome, you're looking at like excitability, because serotonin is a what? Is an excitatory neurotransmitter. Why in neuromalignant syndrome, the clonus everywhere, we are not going to see clonus because I'm having lead pipe kind of rigidity. So there is no, rather we're going to have decrease in tendon reflex and the rest of them. Their reflexes is going to be start going low. Are you following? So take note. So this tells us it is what is specific to what? Serotonin syndrome. Now, onset over approximately 24 hours. Remember I told you serotonin syndrome is more of acute. So it builds within minutes, hours. But neurotransmitter takes time, days, weeks, months. So this is more specific to what? To serotonin syndrome. Now, creatine kinase. Whenever we are having muscle issue, we are going to see rhabdomyolysis is going to occur. So it's going to occur in serotonin syndrome, and as well is going to occur in neuromalignant syndrome. And remember, when someone is having rhabdomyolysis, we want to make sure that they're adequately hydrated so that the kidney can be able to flush out those myoglobulins. If not, client can go into acute kidney injury. So since this is both seen in NMS and is both seen in neuromalignant syndrome, it is not specific to help me to differentiate what NMS and neuromalignant syndrome, right? Now, hyperbole sound and loose tone. Yes, remember I told you serotonin will increase hypermotility of your GI system. Why in neuromalignant syndrome we're going to see decrease? So this is more specific to serotonin syndrome. Temperature rise of 39, we'll have 39.6 degree with diaphoresis. This is not specific. Yes, because in neuromalignant syndrome, temperature will rise and they'll be sweating. In NMS, temperature will also rise. So we don't usually use temperature to differentiate two of them. Are you following? Now, increased both, then the last one said, increase but moderate upper extremity tone. Yes. In serotonin syndrome, remember I told you there's going to be increased movable upper because everywhere is excited. But if it is in NMS, it will be decreased. So these are things that help us to distinguish or differentiate what serotonin syndrome from neuromalignant syndrome. Take note, serotonin is slower in onset. I say serotonin. NMS is slower in onset, and then serotonin is faster in onset. Then in serotonin, you're looking at your signs and symptoms are up. But BP is the same. But take note that BP usually fluctuates. It can be high and then it can be low. So take note of that. Both in NMS and neuromalignant syndrome, BP can fluctuate. So these are the stuffs you need to know. All right, so let's see our answer. As you can see, we got the answer correct. So our rationales are very straight to the point, and it helps you to what to understand, right? So make sure you visit our www.Vic-Nclex Prep Consult to subscribe and get your hands on this kind of a question. So we have the cards, we have so many tutor mode. You can practice unlimited cards, you have so many tutor mode, and then you can generate so many questions. The maximum you can generate at a go is 120. I think the minimum is 5. So take note of that. So make sure you subscribe, and it's very affordable and gives you what you're going to likely see on the real NCLEX exam, right? Our cat is very adaptive. The more you get the question, the harder this kind of question pops out for you. All right, so make sure you follow up, and then we also do live tutoring. Yes, you can also come in and join our live tutoring to help you to build your content. All right, so if you want to join our live tutoring, I would advise you to go to our website and fill the contact form, and then our representative will get back to you. Thank you. To have a wonderful day. This is Vic from Vic-Nclex. Bye.